Good afternoon, everyone. At the outset, I would like to thank AIOS for giving me this opportunity. So, my topic is non-strabismic binocular vision anomalies. Why this topic? We know that our visual demand has increased these days. Previously, when we only read. But now, see, looking at this talk, you will be looking at your mobile in between. So, you have to use your accommodation in between. So, coming to my topic, before doing any non-strabismic orthoptic evaluation, you have to correct your refraction and monocular correction as well as binocular balancing. Because binocular balancing, if you have not done, it itself can give rise to accommodative issues. So I will be covering tests of accommodation, tests of convergence, as well as of some anomalies. So we know that your accommodation and convergence is interrelated. So if you have one problem, it can give rise to the issues in the other also. The previous speaker has already told about the AC by A ratio, how your accommodation and convergence is interrelated. So coming to test of accommodation, you have accommodative amplitude and near point of accommodation. That tells you the strength of your accommodation, and the negative relative evidence that tests your relaxing ability of accommodation, and then you have the positive relative evidence that tests your stimulating ability of accommodation. And other than that, you have accommodation facility and monocular MEM retinoscopy that tests the flexibility of your accommodation. So just see how your accommodation amplitude is, near point of accommodation is tested. You explain the patient very well how you are going to do this. So you can do this with a RIF ruler. The patient has to concentrate on N8 or N7 in the near chart, and you bring the target close to the patient, and the first sustained blur the patient sees, that is measured in centimeters. That is your near point of accommodation. And how will you calculate the accommodation amplitude? Whatever you get, 100 divided by that much centimeter. So if you get a 10 centimeter in your near point of accommodation, your amplitude of accommodation will be 10 diopters. And now you have to measure what is the expected for that age. Accommodation amplitude is related to so many factors. The important one is age. So you have to calculate the expected amplitude of accommodation. You have different formulas like Hofstadter formula, that is 15 minus 0.25 into age, and we have an Indian formula from Dr. Jamila Rizwana, 18.5 minus 0.3 into age, and rule of 4. Coming to negative relative accommodance. Here, what you do, you ask the patient to concentrate on the N8 letter, and you will be, here you are testing your relaxing ability. So you have to put plus 0.25 diopter lenses in increments, and until the patient sees a sustained blur. So that you will taken as the NRI value. Similarly, if you have to test your positive relative accommodance, then here you have to do, instead of plus, you have here just stimulating ability. So you have to put minus 0.25 diopters in increments until the patient sees the sustained blur. That is your positive relative accommodance. Coming to the accommodative flippers. So here what you do is, you have to use accommodations flippers. You can either use a plus or minus 1.5 or plus or minus 2 diopter, and you need a rock card which is using the NA target. Then you will flip the accommodation flipper, and the patient has to read clearly. And if you are getting some 10 flips per 1 minute, then you have 5 cycles per minute. 2 flips will be 1 cycle. Coming to MEM retinoscopy, this is done in a well-lit room, and here the patient first reads this distance vision, then you ask the patient to look at your MEM card, and you see how is the refraction. So if normally we have a plus 0.25 to plus 0.75. If it is more than plus 0.75, then you call it as a lag of accommodation, and if it is less than 0.25, then you call it as a lead of accommodation. Now coming to the next part, the second part of my talk, that is the test of convergence. So here you have near point of convergence, negative fusional convergence, positive fusional convergence, and convergence facility. So how will you calculate the near point of convergence? As if you are doing in NPA, here NPC also you can do either with an RIF ruler, or you can do with a pen light and a green filter. So here you will be moving the target to the patient's nose, and when the patient is not able to fuse, then you record the break point as well as the recovery point. So that will be taken as the near point of convergence. Now negative fusional convergence. Here normal tendency of our eye is to converge. So when you are doing a negative fusional convergence, you have to do it for distance first, then come to near. So here you are testing divergence amplitude. So you have base in prism is placed in front of one eye, and you keep on increasing the prism until the patient sees blur, then break, and then you again come back to the normal place. You will get a recovery point. Similarly, for positive fusion, this has to be done for distance, then for near. Whereas in positive fusional vergence, we will do first for near, then for distance. Same like negative fusional vergence, but here you place the prism base out. Vergence facility, here what you do is, like accommodative flippers, we have vergence flippers, either 12 base out and 3 base in, or 16 base out and 4 base in, and we do it in cycles per minute. How many flips divided by 2 will be your cycles per minute, that much. So these are the normal values. I am not going into the details, that you can find it in any talk. And coming to the anomalies, the accommodation and convergence anomalies give rise to these problems like blurring of vision, double vision, poor concentration and all. So you have accommodation insufficiency, ill-sustained accommodation, infacility, and paralysis and spasm of accommodation. I will be going through the important ones. So in accommodation insufficiency, what happens is the patient is able to see clearly for distance, but after some, when we prolong the reading, everything will become blurred. So here patients have a low accommodative amplitude, and you will get a high NRA but low PRA. Patient is not able to relax accommodation. So fails with the minus lenses in flippers, and MEM lag will be more than 0.75. Sorry, high NRA. And in accommodation infacility means when you read the book, it's everything clear, but when you look at the distance, it's not clear. When you look at a far distance, everything clear, but when you look at the book, it's not clear. So there is infacility for both. So here accommodation amplitude will be normal, but your NRA and PRA will be less, and it fails with the minus and plus lenses. Spasm of accommodation, you will be getting a variable refraction. You have low NRA and high PRA. This is either due to the parasympathetic system overstimulation or poorly functioning sympathetic system. Sometimes in psychogenic factors, cholinergic cues, and secondary to head trauma, all these can lead to accommodative spasm. And paralysis of accommodation, you will get a non-presbyopic patient come with a poor reading. So that can, like Addis people, third nerve palsy, cycloplegic drugs, and trauma can give rise to paralysis of accommodation. Coming to the convergence insufficiency that we commonly see, here fatigue after prolonged near work and poor concentration, and patient will be seeing double for near. When you do an orthoptic evaluation, normally there can be an exophoria of for basin. But here you will get an exophoria more for near than for distance, and your NPC will be reduced. Your PFE, the patient is not able to converge. So positive fusional vergence will be less than 15 diopter. Low AC by ratio, NRA will be less than plus 1.5, and difficulty with the plus lenses. In convergence excess also you will get these types of symptoms, but the patient will be getting intermittent esotropia or esophoria.
Yeah, thank you. You'll have to now.
Okay, thank you for the interest of time. I'm stopping here.
Very good coverage. Good. Thank you. Give her a clap. You know, she has done. In 2017 AIOCMT journal, I had a guest review article on accommodative anomalies in children, because nobody believes that there could be an accommodative anomaly in children because their accommodation is flawless. But no, as what she has said, there are at least four types of accommodative anomalies in children, you know. And then I did about three, PG thesis also on that. And it was really true, you know, what Donders had said before 50, 100 years back actually, that, you know, the children having headache and they are not interested in reading and they go to school, and everybody, they keep on running from pillar to post, you know, koi 5.5 zyada kar de, 0.5 refractive, but no, they have an accommodative anomaly. So you must always consider that if the refractive error is not helping a child, you must do certain accommodative tests, especially accommodative lag and accommodative infacility, what she has said. So in my book also, my textbook which I published last year, is a full chapter on accommodative anomaly in children. You should go for it because that is